This is my presentation on attention process training. Attention process training was created in part by Solberg and Mateer. It is typically used with adolescents and adults that experience a TBI, neurological disorders, or post-concussion syndrome. Activities within this treatment method include sustained, selective, divided, and alternating attention on paced tasks. According to our textbook, the framework of intervention for TBI survivors includes abilities related to determining what the problem is and to do about it, learning how to function despite impairments, enhancing the automaticity of strategy use, and applying what is learned in multiple real-life contexts. The objective of creating this program was to assist in improving the executive functions on those who have experienced a traumatic brain injury. According to the textbook, other treatments for enhanced attention and working memory were not as replicable as the studies that tested attention process training. The first research article asked the question if attention process training is effective in the rehabilitation of patients with cerebral small vessel disease compared to those who receive standard care. SVD is another name for small vessel disease. In this study, one group received attention process training and the control group received standard care for mild cognitive impairment and small vessel disease. This was a single-blind study. Those in the APT group received 2 hours of therapy once a week for 20 weeks. Those in the standard care group did not receive cognitive training, were instructed to live a usual lifestyle, were provided medication, as well as clinic consultations. It was expected that those who participated in the attention process training were to have a better quality of life since they participated in exercises to aid in their daily life. Other areas that were expected to be better than the control group were improvement of cognitive performance, reduction of short-term risk of transition to dementia, and improvement of brain activity at rest. This article shows that this program is effective for those with small vessel disease and mild cognitive impairment. It also shows the effects of this program over 3 years. It can lead to the investigation of this program for those with a different diagnosis. In the next article, it was asked how APT would compare with education in influencing the reports of patients and caregivers on patient performance in a naturalistic setting. Which brain networks will benefit the most from APT and/or education? Will responses to APT and the information reveal insights about the effects of practice? As well as will patients' responses to practice and/or APT differ based on their vigilance ability? In this study, 2 groups were made and a crossover design was used. One block received cognitive intervention and then attention process training. The other block endured intervention of brain injury education and supportive listening. Individuals in Group 1 participated in an A-B design, while the individuals in Group 2 participated in a B-A design. In the first block, participants received 24 hours of attention process training over 10 weeks. In the other group, participants received 10 hours of therapeutic support and education over 10 weeks. Overall, most patients showed improvements. The brain injury education seemed most effective in improving self-reports of psychosocial function. APT influenced self-reports of cognitive function and had a stronger influence on performance of executive attention tasks than was found in the brain injury education therapy. Vigilance and orienting networks showed little specific improvement due to therapy. However, vigilance level influenced the improvement with therapy on some tests of executive attention. This article could lead to larger studies performed similarly to be done. This article could lead to groups with other diagnoses to be offered this treatment in future studies. This study could also lead to a combination of both treatments to be used to better assist future clients or participants. Ultimately, this article shows that attention process training is an effective program to a significant population that deserves further use and investigation. In the final study listed, they questioned whether children with ASD could maintain joint attention with other students, teachers, and family given treatment. The study involved 10 children between the ages of 5 and 7 who were diagnosed with autism spectrum disorder by a psychologist. They were divided into a control as well as an experimental group. Teachers were first asked to rate the students using the teacher's rating of child's joint attention scale, as well as a functional communication questionnaire. The participants met with the lead researcher to test their communication by requesting to play with items that were presented to them along with their joint attention and turn-taking. The researcher would watch to determine if the child would make eye contact, use gestures, follow directions, and initiate by caressing or singing. It was determined that this intervention helped improve joint attention between the participants and the examiner. Once compared to the control group, there was shown to be a significance in receiving intervention that benefited the experimental group. They presented with better outcomes in use of eye contact, gestures, following directions, and initiating by caressing or singing. Attention process training is also referred to as APT3. It is a computer program where the clinician is able to choose from hundreds of tasks to assign to the client. An automated voice directs the client on how to perform the given task, as well as explains the task's significance. After each task, the client is asked to choose the level of difficulty and motivation they had in relation to the task. Once doing this, a chart appears showing how the client did on the activity as well as how they did on the activity in previous attempts. Before the clinician uses any variety of tasks with their client, it is recommended that the client perform a particular set of exercises as a screening measure to see which specific areas they show the most deficit in to better assist the clinician in creating goals and objectives. Previous versions of attention process training included a testing document to be used as a screening measure, and the clinician would select each activity individually from its individual file. This program costs hundreds of dollars, so it is not something that the client can do at home or outside of sessions. Hello there. This program is called Attention Process Training, or APT. APT is basically a bunch of brain games. The point of the games is to improve your attention, focus, and working memory. I have selected a couple exercises I would like us to perform today. Each exercise will only take a couple of minutes, and after the exercise, the program will ask you how hard you thought it was and tell you how well you did, as well as if you have improved since the last time you did the exercises. All you have to do is click start, and a voice will tell you what to do and what the exercise will help. Before starting this program, this screen will pop up. You will then move on to the selected exercise or exercises such as this.
You will hear a series of different noises and sounds. Your task is to press the button when you hear a specific sound. The therapist will say which sound to listen for at the start of the task. Listen carefully to the series of sounds. You are to press the button each time you hear the high tone, like this. Get ready. Begin.
Now you can see after every
Once you complete this task, the survey screen will show this image followed by this record of scores. The clinician may select various numbers of exercises to perform in a session. If the client was uncertain about using the program, the clinician could provide the articles that show the effectiveness of the program or tell the client how this may help them perform one of their daily activities, such as conversing with family. A client may have difficulty using this program if they are unfamiliar with computers, cannot comprehend the directions provided on the program, or if they have limited mobility of their arms and hands. The clinician could create the materials needed to perform the exercises without the client using the program. And that is my presentation.